Thanks very much for the opportunity, Neeta and Sanjay. And just to be in the chair with Dr. Humphreys, who we go from UK on the training days of specialist registrar to listen to his talk, and to be in the same panel or the same time is great, actually. Now, hyperthyroidism, current concepts, what I thought will be useful for the practitioners would be just 5-6 case scenario. Next 12 to 13 minutes of talk will be with one case based on the therapeutics, and also what are the differential diagnoses we should think of when we get a hyperthyroidism patient in the clinic. So these are the common conditions that we know that we normally face up in the clinic. So this is a 20-year-old unmarried woman with periorbital edema, mild proptosis, and you got TSH suppressed, and also you are discussing about the therapy with the patient, and patient would like to go on antithyroid medication. Rightly so, this is the graph of how you normally approach. So when you have a typical hyperthyroid case, you go into differential of Graves and thyroiditis, struma ovary, and other things. And if you got a subclinical sector, which is in the other side, and also the rare conditions, which we'll have a brief talk later. So this is the conditions which normally you have with hyperthyroidism. So how do you confirm? And you do need a radioactive iodine, and why do you need it? Because just to confirmation and also differentiate the type and the cause of hyperthyroidism, and also calculating the dose for iodine 131 therapy. So, and also structurally, we would like to know more about the condition. So that is the other reason you do the imaging. So when you do a 24-hour radioactive iodine uptake imaging, it's 84%, and that's confirmed Graves' disease. And so my question to you is, why do you treat, and which drug to be treated with, and for how long, and what are the drug dose, whether it influences the chance of remission, which is very important for us in the clinic. So just to see that we need to treat for these reasons, that it is a cardiovascular condition if you leave it alone, and also this is the way that you approach it. Normally you go with hyperthyroid, anti-hyperthyroid medicines along with beta blocker and CCBs, and radioactive iodine on the other side, and surgery is another option when you don't have a medical therapy, and also the option of radioactive iodine is failed. So which drug to be used, PTU or carbimazole? And this is the reason that you normally think about the drug. People on prolonged medications is also possible, but I'll come to that in a minute. So these are the drugs for propylthiouracil, methimazole, and carbimazole. The mechanism of action is inhibiting the thyroid peroxidase, and this one has got an additional action of blocking T4 to T3 action. So that is a very convenient drug, and it also helps in the pregnancy conditions where ability to, Anjali will be covering that, but less transport through to placenta and barrier and milk. So methimazole will lead to rapid normalization of compared to PTU, thyroid function. So agranulocytosis is the risk. I'll come to that in a minute. And drug-induced hepatitis and ANCA is mostly present, exclusively seen in the conditions of PTU. So methimazole should be used in each and every patients according to the 2018 guidelines. So for how long it should be treated? 3 to 6 months after the medication is stopped, you just need to, the relapse happens. So plateau in 1 or 2 years, and approximately the recurrence rate is 50 to 60%. So how do you predict the relapse? Younger age group, goiter, smoking is the one thing that you normally discuss with the patient and explain, even discourage the passive smoking. And also TSH receptor antibody. I'll come to the evidence in a minute. So the duration is the 18 months seems to be very reasonable time to treat, and the longer the duration of therapy and significantly lower relapses happens. And block and replace, if you do it, it doesn't matter the time duration in block and replace, but the conclusion is optimal duration of antithyroid is between 12 to 18 months, and the high recurrence rate only after 6 months, with no apparent additional benefit by extending therapy beyond 18 months. So when you got a patient in front of you, you just need to discuss the possibility of potentially treating for 18 months, but a lot of people can get a remission before that. So 18 months is the duration. And I discussed about TRAB, which is the thyroid receptor antibody. How many of you do in your clinic? TRAB antibodies, yeah. So 5 or 6 people lifting the hands. It's an expensive test, but you cannot do for all the patients with hyperthyroidism. But when you want to monitor the progress and when you want to explain the possible progression, then you need to do it. So there is a direct relationship between relapse and TRAB. So even after stopping of 12 to 18 months of therapy, you do a TRAB level. And based on that, if there is a persistent TRAB level, then you have to go for radioactive iodine therapy if you get the relapse back, which you normally tend to get if the TRAB antibodies are positive. But 2016 American guideline shows that continues approximately 12 to 18 months of therapy, then discontinue, do a TRAB level at almost a year's time. So this is the drugs versus radioactive iodine. I've just shown the recurrence rate is slightly less with radioactive iodine, but however, the hypothyroidism rate is more high in radioactive iodine, which is a good thing. And in some cases, you have to just counsel the patient that you might be going on another drug, which is a thyroid replacement therapy. Sometimes it's hard to convince the patients because it is another thyroid drug. According to them, everything is a thyroid drug. So pregnancy and lactation is contraindicated radioactive iodine, and it just a comparison of the two treatments which is available at that time. So the fight is still on which one is to go for, but the evidence shows, I think, even if you want to go for a long-term MMI and the radioactive iodine, it's almost 72 to 84 months trial, and these are the side effects that happen. So almost, I'll just show the conclusion bit showing the long-term low-dose MMI for 60 to 100 months is safe compared to radioactive iodine treatment. So you can use either of it, nothing wrong with that. So among the selecting the drugs, methimazole is better compared to PTU. So does the drug, next question is, does the drug dose influences the chances of remission? The answer is, I think it is logical to use the higher dose drug, but depends on the severity. So this trial shows that 509 patients comparing the remission rates with 2 fixed doses, and it shows that higher dose is useful only in severe cases. So that, just to summarize, so 20 milligram dose was low in severely hyperthyroid patient, more severely hyperthyroid patient, but however, it is adequate for less severely hyperthyroid patients. So the conclusion is, in treating hyperthyroidism, 20 milligram a day cobimazole is very effective, convenient patient with mild to moderate hyperthyroidism. So higher doses are required only in the cases of severe hyperthyroidism. And beta blocker and CCBs can be used along with that just to control the symptoms. Should be monitored every 3 to 6 months just to find out the relapse that happens during that time. So coming back, you using the drug, you want to know the side effects. So these are the side effects, agranulocytosis. So normally I tend to explain to them that when you get a sore throat, you need a blood test just to, and I'll document in the notes, which is the practice we've been doing for a while. So document in the notes and agranulocytosis risk explain, and give a blood form in case if they have a sore throat, just they can do a white cell count and check whether they got agranulocytosis. So this is the other side effects. You might have seen in your experience that ANCA-positive vasculitis is not uncommon, but when you look at it and when you see more and more thyroid patients, you tend to see them with that. But the cholestasis and itching can also happen in the practice if you're doing it primarily with that. Another thing is when the patients are diabetic, along with that, it is extremely challenging to manage when they have a thyrotoxicosis. You're giving an antithyroid drug, and you will have a midday, I should say, or the evening hypoglycemia typically happens because the anti-hyperglycemic drug is there, antithyroid drugs are there, so the hypoglycemia, it will be very interesting to do a CGM and monitor these patients who got thyrotoxicosis along with the diabetes. So these are the most feared side effect, and the risk of gay granulocytosis is greater in older patients, and they have higher death rates. So you should remember, I managed one case just started by another doctor, which is really cruel to be managed, and to see a young lady's family every day saying that the critical condition. So it can be a really nasty condition. So as I said, you can just say acute pharyngitis and other infection, oral cavity is more clinical common presentation at that stage. Okay, so I went through a case where what drug to be started, comparing radioactive iodine with the oral therapy, and what dose, whether it's useful, and what is the duration you need to treat, and what are the potential side effects. Now, just coming to another common condition that we face up in the clinic. So Roger is 40-year-old, difficulty in swallowing, pain in the front of neck, mood swings, perspiration. Anyone with the diagnosis? Pain in the neck? Yeah, thyroiditis. So pulse is 86 per minute, and you got TSH suppressed and mild elevation of thyroid function. This is the uptake scan that showed 0.5%. So it is a typical. So when you got a low uptake thyroiditis and exogenous thyroid hormone and excess iodine exposure, or the diagnosis you should consider. But however, if you got a higher uptake, then you got other conditions to think of. So what are the treatment typically? You just give NSAID. Mostly the prednisolone is extreme rare case. I don't use that much, but I think NSAID should do, and then reassurance from your side to the patient, and that would help a lot. So this is the third case, breathlessness and palpitation, progressive breathlessness, and increased frequency of palpitation, increased agitation. So GCS is 15 and temperature is 101. There is a postural drop, probably volume related, but JVP is up. Bilateral edema, ankle edema, and you see nil of note. So there is nothing else. So what are the probable diagnoses? So fast AF is a possibility. So with the temperature, you can think of chest sepsis. Any other possibility because it's a thyrotoxic talk? Okay. So this the white cell count is slightly up, and you can see not much of inflammatory markers have gone up. CRP is not that high. I mean, you need really CRP of 100, it's a good going infection. So that shows atrial fibrillation, and we got that one. Now, can anybody come up with a diagnosis? It's a rare condition, isn't it? So it is thyrotoxic crisis, rare but fatal disorders that needs immediate treatment. These could be the precipitating factors. So that should be a catabolic state in the body just to bring up a big problem like this. So you can have a clinical features like hyperpyrexia. It's almost like extreme sympathetic activity, and psychosis can be there, tachycardia, and CCF could be there. So how do you manage? You just do anti-thyroid treatment and also iodide, and just a beta blockade would be very useful. Esmolol, the short-acting beta blocker, has got, you can assess the patient easily when you use the short-acting one, and glucocorticoid therapy, of course, and a supportive management at ICU will be very helpful. This is a condition that if you see once in life, you won't miss it. So next case is a 28-year-old with palpitation and breathlessness, recent onset of tachycardia, and this is the thing I want you to focus: pancytopenia and self-administration of cytotoxic drug and antiretrovirals. It's a complex psychiatric history. Borderline personality disorder, so heart rate is 140. So these are all way high. Anyone can come up with any diagnosis? So TRAB is almost 0.2, so there's nothing there. So no uptake in thyroid scan. So that shows normal size parenchymal pattern, and ultrasound thyroglobulin is undetectable. So this is the factitious thyrotoxicosis. This is, you should think of, there is a possibility of this. So this is the fourth condition I want you to think about, and this is the last one. 49-year-old with palpitation, 2-year history of sleep disturbance, anxiety, and heat intolerance, palpitation, tremor, and we got a dilated cardiomyopathy attributed to the alcohol, episodes of non-sustained VT is there. So beta blocker is there, ACE inhibitors, furosemide, and aspirin and atorvastatin. So you typically manage as a proper cardiac condition with a VT in the background. So family history, diagnosed with thyrotoxicosis in 1955, that's mother, and subtotal thyroidectomy has been done. So there is some dodgy thing is happening in the family. So hypo, hyper, all are there. So it's a strong family history there. Cardiovascularly tachycardic, and respiratory rate is 18, and there is no other condition saying it is Graves' disease. So we got a thyrotoxic patient with query cause. So the TSH 2.9. Anyone can think of any possible diagnosis? What do you want to rule out? So we went through a case of Graves' disease, thyroiditis, facetious, and also a rare condition of thyroid storm. So this is the last one. Anyone can think of? TSH is normal, but patient is thyrotoxic. What you would like to know? Yeah, free T4. So that is elevated. Now, possible diagnosis? So these are the possible diagnoses. The TSH assay interference is possible, resistant to thyroid hormone, possibly the family would have got operated wrongly, and then the TSH OMA, which is TSH secreting pituitary tumor. So that is the CT you wanted, and it shows TSH OMA. So the take-home message is elevated T4 and T3 with suppressed TSH is the most common presentation in thyrotoxicosis. And we discussed the common conditions, the Graves' disease, and other conditions are toxic MNG and toxic adenoma. So elevated T4 with unsuppressed TSH has got three differential diagnoses. The assay interference, you just need to go through the biochemistry with a different lab, and also TSH OMA is a condition which you should think of under resistant to thyroid hormone. So if you got an atypical thyroid function test, you need to evaluate rather than just labeling. Especially in India, patients go to different labs at different times, and the challenge is to interpret the thyroid function with them. So just to conclude, the diagnosis is important to plan treatment, and T4 is the one which will guide us a lot, and long-term plan should be in place, and over-diagnosis is, and over-treatment is better in STORM. I stop there, and as Krishna said that we got 2 minutes if you want to discuss anything. So I went through the just to summarize what I went through, it is just a thyrotoxic patient approaching you, the common things to think for, how do you approach with imaging, and what are the medical management that you can think of, how long you treat, what are the side effects you expect, and what is the other conditions when you have a viral infection preceding and pain in the neck and other things. And then the third one is to think of the rare conditions like thyrotoxic storm. When you got a temperature and everything in India, it's just common to think about infections all the time, but you should also consider a catabolic state. And then about the facetious thing with the drug-induced and other things. And then the last one is about thinking about TSH resistance syndrome, TSH OMA, and also the TSH secreting tumor.